Hello everyone and welcome back to Clinical Cousins YouTube channel, where today we're going to explain in very simple terms how you can quickly read and understand a cardiac pressure volume loop. So these seem to confuse a lot of people, so what we're going to do is we're going to make it extremely simple. You're going to be able to take a look at one of these and know exactly what is going on. So first off, volume goes on the bottom and it's in milliliters, so our x-axis is volume, and our pressure goes on the side, it's in millimeters of mercury. So we're going to make a graph, but what are we going to make a graph of? What are our maximums and minimums? Well, the volume you can see will go up to about 140 milliliters in a healthy person, and the pressure will go up to about 120 millimeters of mercury in a healthy person. So what is this pressure volume loop? Well, it's really just a graph of a cardiac cycle. So let's start off with our isovolumetric ventricular contraction. So we know that at the end of diastole, we have the end diastolic volume. This is about 140 milliliters normally. So as the ventricle contracts, we know that all the valves are closed. The ventricle is building up pressure. Now notice that our volume has not changed, but we are increasing our pressure. We can see that our pressure is slowly rising as we're contracting. So we label this 1 and 2. Okay, so what happens when our ventricle finally overcomes that afterload, when it is able to eject blood from the aorta, when the ventricular pressure is actually greater than the pressure in the aorta? What will happen when we have rapid ventricular ejection? So we know that we're going to be squeezing and generating pressure, so our pressure is going upwards, but we're going to be losing volume as it enters the aorta. So our pressure is increasing, we're losing volume. So this is why we are losing volume. We're squeezing into the aorta, but our pressure is still going up. So we label this rapid ventricular and slow ventricular ejection. And we know that these are between 2 and 3. Okay, so what happens next? Well, we know that once the ventricle is done squeezing, there will be a drop in pressure and its semilunar valves will slam shut. So the ventricle has some blood left in it. We can see that this is when it's relaxed. It still has some blood. It's about 70 milliliters, but it's rapidly dropping in pressure as that ventricle sort of relaxes. So we have the same volume of blood, but we're losing pressure. What do we call this? Yes, this is isovolumetric ventricular relaxation. Isovolumetric, same volume of 70 milliliters. Ventricular relaxation, we're dropping in pressure. So we see that this is between 3 and 4. Okay, so now the ventricular pressure is really low, lower than the atria even, which have been filling with blood this whole time. So in this point in our mind, we can visualize the AV valves are now open and blood starts to come into the ventricle. So because the ventricle is relaxed and it's stretchy, it starts to accumulate blood without really causing an increase in pressure. So we see that our volume is going up, but our pressure is not really going up as much as you would expect. It's because our ventricles are compliant. So we know that this phase that I'm talking about is called rapid and then passive ventricular filling. And the second term right here, the second part of the cardiac cycle, is called diastasis. It's where most of our filling takes place. So we see that these phases are located between 4 and 1, and we also know that as we near position 1, that atria is going to give us one last kick of blood, the atrial systole, and now our cardiac cycle is complete. So this is why between positions 4 and 1, we see that the ventricle is increasing in volume on our x-axis, but we're really only slightly increasing in pressure on our y-axis. Okay, so this is kind of what everyone has a very vague grasp of, but now I'm going to blow your minds. So notice how this right here, the maximum amount of ventricular filling, is really our value for end diastolic volume. Our preload, this is about 140 milliliters. So notice here that the blood in the left ventricle at the end of systole, this is really our end systolic volume. So what can we make of these two values? Yes, we're talking about stroke volume. So our stroke volume is how much blood we squeeze out with each heartbeat. So we take the end diastolic volume, which is about 140, and then we subtract it by the end systolic volume, which is about 70. So in simple terms, we're going to see how much blood do we start with, and then how much blood did we end with? So we know that's end diastolic volume minus end systolic volume, which gives us, in our healthy person in black, about 70 milliliters of blood. This is our stroke volume. So what else can we do with stroke volume? Well, we can find the ejection fraction. So this is the percentage of blood that is ejected from the heart. And this is used to monitor heart failure. So ejection fraction tells us how strong our heart is, or really how well it contracts, its contractility. So ejection fraction is stroke volume over end diastolic volume. So in simple terms, how much did we squeeze out versus how much did we start with? So usually, or in this person at least, our stroke volume is around 70 milliliters and our end diastolic volume is around 140 milliliters. So we can see that we put 70 over divided by 140, this is about 50%, it's about half. So you should know that a normal ejection fraction can range from about 50 to 75% depending on what grading system you use, but really an ejection fraction below 40% is a bad sign because it indicates heart failure. Remember, heart failure is really just our heart is not an effective pump anymore. It's not squeezing like it should. So let's take a look at another aspect of this graph, only this time let's increase our preload. Let's increase our end diastolic volume. Well, how will we do this in real life? Well, we're going to do this by maybe giving our patients a bolus of saline to increase their blood volume. We're going to put some compression stockings on, and we're going to throw their legs above their heads so all that venous return comes and it increases our preload. And for good measure, we can give them some light alpha-1 agonist to put some of that unstressed volume into the arterial stressed volume. So let's say that we've done that, we've waited 30 minutes, and let's see what the graph is going to look like when we increase our patient's preload. So we're going to see that in orange here, this graph is a lot wider because all we did was we increased the end diastolic volume to about 180 milliliters. That's a lot. So we can see that the increased stroke volume of the heart, really stroke volume is here to here, right? So we can see that there's an increased stroke volume of the heart, which will increase our cardiac output. Remember, cardiac output, heart rate times stroke volume. So we're increasing our stroke volume. Okay, now we're going to kind of do the opposite. We're going to give them some afterload, some increased afterload. And let's really give it to them. Let's give them some aortic stenosis so that that ventricle has to work really hard to generate enough pressure to squeeze out the blood through that tiny aortic hole. So we can see that this graph here in blue is a little bit more narrow and tall. And why is this? Well, it's tall because the pressures are higher. The ventricle, which is squeezing right here, it has to overcome tons and tons of pressure just to shoot out its blood into the aorta. So also, it's more narrow because there's only a small pressure window where the ventricular pressure is actually greater than the aortic pressure. This means that our stroke volume, you can see, is going to be considerably less. Remember, our ventricles can only generate so much pressure. So this brings us to the important concept of cardiac work. So cardiac work tells us how hard our heart has to work. So how hard is our heart working? That's a tongue twister for you. But when the heart works harder, it is going to need to be paid more, meaning it is going to need more nutrients and more oxygen in the form of blood. So if we break this down, cardiac work right here is really just cardiac output times the aortic pressure. Meaning cardiac output is what our heart is trying to push forward, and the aortic pressure is what's stopping us from pushing. So the clinical relevance here is that pressure work is always more costly than volume work. So I'll say that again. Pressure work is always more costly than volume work. So this is the important thing here. The heart needs way more oxygen payment if it is going against a lot of pressure. And it doesn't need quite as much payment when all we have to do is move a lot of volume, when all we have to do is increase our cardiac output. So which is more costly? Some moderate aerobic exercise like maybe somebody's walking, or some uncontrolled hypertension in a person sitting down and reading a book? Well, before this video you might think, oh, well, the person who's exercising, they're going to be straining their heart far more. But the truth is that the person who's sitting there reading a book with hypertension, they have a lot of this, right? They have a lot of aortic pressure. They have a lot of pressure work to be done. So the truth is, the person with hypertension who's just sitting there reading a book is putting more of a strain on their heart than, say, the person who is lightly walking. So this can be understood by visiting the law of Laplace. So pressure, this formula really just goes, pressure is 2 times thickness times tension over radius. And you don't need to memorize this per se, but the importance here is that when our heart needs to increase its pressure because of, say, hypertension or some sort of valve stenosis, when our heart has to work really, really hard, it has a lot of pressure work, it's going to generate that pressure, but how does it do it? Well, it's going to increase its thickness by adding some muscle. And you're going to say, why, Christian, that sounds like an awesome thing. I go to the gym to get my muscles jacked. Why don't I want my heart to just be ripped? Why don't I just want it to be full of muscle? Well, you don't. At first, this is a compensatory mechanism that helps us meet our demands by increasing the pressure. So initially, it's a good thing because, oh, we're going to meet our demands and everything's going to be okay. But over time, the heart actually becomes really big and floppy. This becomes an ineffective pump. So this, over time, this big floppy heart needs more blood payment just to be a bad worker. This is why it's so important for us to manage our patient's hypertension, which we know is often asymptomatic, so people really don't pay a lot of attention to it, and to make sure that they don't have or develop any murmurs or anything that would increase our afterload for extended periods of time. Remember, this is a bad thing. We don't want our hearts to be jacked. We don't want them to be full of muscle. So instead of big floppy hearts, we want strong, lean hearts that can beat for a long time. So as always, thank you for taking the time to learn with us today, and I hope that you like and subscribe for more content. Thank you.